Hello viewers, good day to all of you. This is Dr. BK for you with another lecture on the upper limb, that is the shoulder region. So today we are actually going to discuss about the shoulder region in detail. So in this lecture we will be mainly discussing about the deltoid muscle. So we will be actually learning about the deltoid muscle in detail, followed by certain spaces within the muscles which are actually called as the intermuscular spaces with respect to the shoulder region. Followed by this, I will be talking about the axillary nerve, the branches of the axillary nerve, the structures supplied by the axillary nerve, then about the anastomosis around the scapula, that is mainly the arterial anastomosis around the scapula, then of course the applied anatomy of all the above mentioned structures. Okay, so since I have listed out the objectives of this class, so now I will move to these topics one by one. So at first, what you see here is the shoulder region. Whenever we talk about the shoulder region, what comes to our mind is the deltoid muscle. So this deltoid muscle is a very powerful muscle, and mainly it covers your shoulder joint and the structures around the shoulder joint. It is mainly responsible for the rounded contour of the shoulder. So if your deltoid muscle is very well developed, then what happens is you get a very built and a very smooth and round contour of the shoulder. Then the deltoid muscle is also an example of the multipinnate muscle. Not the whole deltoid muscle is of multipinnate type. Mainly the middle fibers are actually of multipinnate type. So what is multipinnate? Feather-like. We have seen unipinnate, bipinnate, multipinnate, circumpinnate. Okay. So why you need a multipinnate muscle? We will come to it a little later while we discuss about the actions of the deltoid muscle. The origin of the deltoid muscle, it originates from three sources. One is from the inferior edge of the spine, of the crest of the spine of the scapula, that is the lower border of the spine of the scapula. It's called as the crest of the spine because it is sharp in nature. So from these, what arise, this number 3 what is labeled here, the posterior fibers arise. The middle fibers you see here actually arise from the lateral border of the acromion. So from the lateral border of the acromion, the middle fibers arise, and the anterior fibers you are able to see here arises from the anterior border of the lateral 1/3 of the clavicle. Okay, so it arises from the lower border of spine of scapula, lateral border of acromion, middle fibers, anterior fibers from the lateral half of the anterior part of the anterior surface of the clavicle. So if you look at it along the side view or lateral view, you can see they have a continuous V-shaped origin. All these fibers, they converge and they get inserted into the deltoid tuberosity of the humerus. So the deltoid tuberosity of the humerus is actually present on the lateral aspect of the shaft of the humerus at the junction of upper 1/3 and the lower 1/3 of the humerus. You come across the deltoid tuberosity of the humerus. Now supply, it is mainly supplied by axillary nerve, posterior cord of brachial plexus. The axillary nerve is a branch of the posterior cord of brachial plexus. We will see that later. So here we are able to see how the axillary nerve comes very intimately related to the surgical neck of the humerus and then supplies the muscle from its deeper surface. Okay. So remember, axillary nerve is actually the nerve supply. Now coming to the most important part of the deltoid muscle is about the actions which it is going to perform. So yes, middle fibers, here you are able to see these set of fibers from the lateral border of acromion. They are the powerful abductors of the arm. Abduction of the arm from 15 to 19 degrees. From 15 degrees to 90 degrees, the abduction of the arm is actually brought about by the deltoid muscle. Now, this action is a powerful anti-gravity action. That means you have to raise your shoulder or arm against the gravity. So that is why you need a very powerful muscle, and you have the middle fibers of deltoid which are multipinnate. So why you need a multipinnate is because large number of fibers can be packed, concentrated in a very small area, and that is actually called as the multipinnate muscle. Apart from that, the anterior fibers, they are involved in the flexion of the arm and medial rotator of the arm. So they flex, the medial rotate. Anterior fibers can also adduct the arm. The posterior fibers you see here, which is actually arising from the scapula, spine of scapula, they are extensors of the arm and lateral rotators of the arm. Now, usually extensors and lateral rotators, they mainly are involved in the abduction. But here, since the middle fibers are powerful abductors, both the anterior fibers and the posterior fibers, they adduct the arm. So anterior fibers, they flex and medially rotate. Posterior fibers, they extend and laterally rotate. In addition to that, it also performs adduction. So as I told you, it is from 15 to 90 degrees. Initial 15 degrees is actually brought about by the supraspinatus muscle. So the supraspinatus muscle initiates the abduction mechanism. Now coming to the relations of the deltoid muscle. So that is structures under cover of deltoid muscle. So why I am actually describing the deltoid muscle in detail is because this is expected as a separate question of the muscles. This muscle gains importance because of its action, because of its function, because of its situation. Okay. Now, bony structures which are covered under the deltoid is very well. If you remove the deltoid, you will be able to see the shoulder joint. So the head of the humerus and the glenoid fossa is under the cover of deltoid. Then what else you have is the coracoid process is under the cover of deltoid. The greater tubercle and the lesser tubercle of the humerus is under the cover of deltoid. Naturally, between these two tubercles, the intertubercular sulcus also is under the cover of deltoid. So head and the two tubercles and the upper part of the shaft, that is upper 1 to 2 centimeters of the shaft, is actually under cover of the deltoid muscle. So when you have an idea about the bones covering the deltoid, then naturally the muscles covering the deltoid can easily be remembered, because what are all the muscles attaching to this part of the bones? If you just list out the names of those muscles, then it will be sufficient enough. Okay. Now next to the bones, what you see here is certain bursa. So here you are able to see this is actually the capsule. Apart from that bursa, this is one bursa, this is one bursa, subdeltoid bursa, subacromial bursa. Okay. So here subdeltoid bursa beneath the deltoid, subacromial bursa behind the coracoacromial arch. One more bursa is here behind the insertion of subscapularis muscle, that is actually called as the subscapular bursa. So three bursas are there under the cover of the deltoid muscle. So I have already explained to you what is the function of the bursa. So the bursa, what happens, prevents the friction between the bone and the muscle. It's mainly lubrication in nature. So here, are you able to get an orientation of all the structures? We are actually viewing the shoulder from above. So here, what you are able to see here is the spine continuing as the acromion process. This is the coracoid process. Head of the humerus is completely hidden from the view because of the ligaments. And here you see the greater tubercle and little bit lesser tubercle. This is front of the scapula. You are able to see the front of the scapula. The deltoid muscle here, they have been cut and reflected for you so that all these structures are exposed. So muscles, insertion into the intertubercular sulcus, pectoralis major, coracoid process, pectoralis minor, short head of biceps. Supraspinatus, infraspinatus, teres major going to the greater tubercle, subscapularis going to the lesser tubercle, forming the rotator cuff muscles. Okay. Apart from that, you also have the long head of biceps and long head of triceps. So again, from superior view we have seen, this is from the lateral view. Once the humerus has been removed and the deltoid has been cut to expose the structures underneath, shoulder joint, glenoid fossa with the glenoid labrum, capsule. Okay. So immediately above supraspinatus muscle you are able to see here. That is the supraspinatus muscle. Infraspinatus, teres minor, teres major, subscapularis, latissimus dorsi, short head of biceps, long head of triceps from infraglenoid tubercle, long head of biceps is not shown here. Okay. So these are the muscles which are under the cover of the deltoid muscle. So we have seen certain muscles, then bursa, then bones, and of course joint. The shoulder joint is very much under the cover of the deltoid muscle. Now, apart from that, the nerve which is winding around the surgical neck of humerus, the axillary nerve, and these two vessels which are again winding around the surgical neck of humerus, that is the anterior and posterior circumflex humeral vessels, they are also under the cover of the deltoid muscle. So we have seen bones, bursa, muscles, vessels and nerves under the cover of deltoid. So when a deltoid muscle is actually asked as a question in the university exam, then naturally you are expected to write about the origin, insertion, nerve supply, detailed action, relations, and finally complete it with the applied anatomy, which I will be speaking at the end of this lecture. So now coming to the intermuscular spaces, we have already seen certain spaces in the back region. Very well, I think you remember those two spaces, triangular spaces, which is called as the triangle of auscultation, and other one is the lumbar triangle. In the same way, around the shoulder or the scapular, between the scapular muscles, when the scapular muscles come and insert into the humerus, there is some spaces which you come across. They are called as the intermuscular spaces. They are called as potential spaces because they transmit structures. So mostly what do they transmit is the nerves and the vessels. So these spaces are utilized for the passage of the nerves and vessels. So three spaces you come across. In the upper part, what you see is the quadrangular space, because it is quadrangular or four-sided. Then you are able to see an upper triangular space, three-sided space. Then below the quadrangular space, you see one more space which is actually called as the lower triangular space. Three spaces: quadrangular space, upper triangular space, and lower triangular space. Okay. So these spaces, what do? They actually transmit these structures, all these spaces: quadrangular, upper triangular, and lower triangular space. So very simple. You can actually, with your fingers, you can make this shape, and you can learn or memorize or recollect the upper and lower triangular space based with your index finger and the middle finger of the both hands. You can use it. So now you are able to see the the quadrangular space, the upper triangular, and the lower triangular space. Okay. So these spaces, it has the boundaries and it is going to transmit certain structures. Now this is a very schematic or diagrammatic representation of these spaces, which is very easy to reproduce for you. So that is why I have included this picture for you. Okay. So that is one more photograph showing that quadrangular and triangular spaces. Now we will see the boundaries and contents of each of these spaces one by one. The first space is the quadrangular space. It is immediately present below the shoulder joint. So that is why the upper boundary is mainly formed by the teres minor. You see the teres minor muscle. Anteriorly, what you see is the subscapularis muscle, insertion of subscapularis, or the subscapularis muscle on its way to the insertion. In between these two, what you have is the capsule of the shoulder joint. Below, the lower boundary is mainly formed by the teres major muscle. So that is the teres major going to the medial lip of intertubercular sulcus. And medially, what you have is the long head of triceps, which is arising from the infraglenoid tubercle and on its way to the olecranon process of the humerus. Laterally, surgical neck of humerus. Okay. So laterally surgical neck, medially long head of triceps, inferiorly teres major, above teres minor, capsule of shoulder joint, and subscapularis from backwards to front, or you put it reverse, vice versa, it is from before to backwards. Now what does this transmits? Axillary nerve passes through this quadrangular space along with one artery, that is the posterior circumflex humeral artery. So the contents are axillary nerve and posterior circumflex humeral artery or vessels, corresponding vein. So that is the axillary nerve and the posterior circumflex humeral vessels winding around the surgical neck of the humerus on its way to supply axillary nerve on its way to supply the deep surface of the deltoid muscle. The next space is the medial or upper triangular space. So that is the upper triangular space. It is between the axilla and the posterior scapular region. The boundaries of the upper triangular space, you see here, this is the upper triangular space for you. Teres minor above, teres major below, and medially long head of triceps. Okay. The long head of triceps, which served as the medial boundary for the quadrangular space, now it becomes the lateral boundary for the upper triangular space. So once again, I will repeat the boundaries of the upper triangular space. Teres minor above, teres major below, and laterally you have the long head of triceps. So what passes through this upper triangular space? So the upper triangular space transmits circumflex scapular vessels. So it is on its way to the infraspinous fossa. There it is going to give branches and it is going to anastomose with the neighboring arteries which are going to come here, and that we will be seeing in the anastomosis around the scapula. So upper triangular space transmits circumflex scapular vessels. So here you are able to see this one through which the circumflex scapular artery, which is a branch of subscapular artery. The subscapular artery in turn is a branch of the third part of axillary artery. Okay, circumflex scapular vessels in the upper triangular space. Next, we will be discussing about the lower triangular space. So here, the lower triangular space, here you are able to see here, it looks like an inverted triangle, apex directed below and the base directed above. So the boundaries of the lower triangular space, medially long head of triceps. So you are able to see the long head of triceps. It is on its way to join with the medial head of triceps. So medially long head of triceps, laterally shaft or the medial border of the shaft of the humerus. The medial border of the shaft of the humerus. Superiorly what you have is the teres major. So the three boundaries are medially long head of triceps, laterally shaft of the humerus, superiorly teres major. So the teres major forms a superior boundary for the lower triangular space, whereas for the quadrangular and upper triangular space it forms the inferior boundary. So coming to the lower triangular space, contents are radial nerve and profunda brachii artery. Radial nerve and profunda brachii artery. So here you are able to see the radial nerve and profunda brachii artery. Radial nerve is again the largest branch of brachial plexus and it arises from the posterior cord of the brachial plexus. Profunda brachii artery is actually a branch of the brachial artery. Both are on its way to enter into a groove on the posterior aspect of the humerus, the spiral groove or the radial groove. So that is the lower triangular space for you with the radial nerve and the profunda brachii vessels. Okay. So we have seen about the upper triangular space. We have seen about the lower triangular space. Then we have also discussed about the quadrangular space. Contents: quadrangular space transmits axillary nerve and posterior circumflex humeral vessels. Upper triangular space, circumflex scapular vessels. Lower triangular space, radial nerve and profunda brachii vessels. So now we will discuss certain aspects of the axillary nerve. So here you are able to see the axillary nerve, which is brown color. It is a branch of the posterior cord of the brachial plexus. Okay, so it is actually a branch from the posterior cord of the brachial plexus and its root value is C5 and C6. Given in the axilla, the branch is actually given in the axilla. So it passes along the posterior wall of the axilla, inferiorly and laterally, and it is going to enter into the quadrangular space. So it enters the quadrangular space along with the posterior circumflex humeral vessels. So here we are able to see here now it has entered the quadrangular space along with the posterior circumflex humeral artery, and it will be dividing into an anterior branch and a posterior branch. So the axillary nerve before supplying usually divides into an anterior and a posterior branch. Okay. Now, as it passes through this surgical neck of the humerus, definitely what happens is it is closely related to the capsule of the shoulder joint, and it also gives a branch, articular branch to the shoulder joint. So here you should actually recollect about the Hilton's law. So Hilton's law states that a muscle acting on the joint, so naturally the nerve supplying that muscle will also supply the joint and also the skin covering the joint. So your deltoid nerve is, your axillary nerve is going to supply the shoulder joint, and of course the muscle covering the joint or passing through the joint, the deltoid muscle, and naturally ultimately it will also pierce and supply the skin over the joint. Okay, so anterior branch winds around the surgical neck and supplies the deltoid from its deeper aspect through its lower part. So anterior branch. Coming to the posterior branch, so here you are able to see the blue colored one is actually the posterior terminal division of the axillary nerve. Okay, so that is going to give a branch to the teres minor muscle. Before giving a branch, it will form a thickening which is actually called as the pseudoganglion. The pseudoganglion is not a classical ganglion. Ganglion is a collection of neurons or nerve body soma outside the central nervous system. So this is not an exact collection of neurons, it is only a thickening of the axon. So it is not a dorsal root ganglion or for that matter sympathetic ganglion or any other ganglion. Just shows a thickening. The axillary nerve shows a thickening to the branch to the teres minor. Then afterwards it gives few branches to the deltoid muscle, then emerges from the posterior border and supplies the upper lateral part of the arm as the upper lateral cutaneous nerve of the arm. Okay, so naturally the Hilton's law is satisfied here. So posterior division supplies what else? Teres minor, branches to the deltoid and the skin above the upper lateral part of the arm. So to summarize, the axillary nerve is going to supply your deltoid muscle, teres minor muscle and your shoulder joint. Now, since it is very closely winding around the surgical neck of humerus, fracture of the surgical neck of humerus, one thing, or dislocation of the shoulder joint, most commonly inferior dislocation of the shoulder joint, can actually damage this nerve or injure this nerve. So axillary nerve is injured during the surgical neck of the humerus fracture and also during the dislocation of the shoulder joint, most commonly in the inferior dislocation of the shoulder joint. So next what we are going to deal is the anastomosis around the scapula. So this is again a very important topic, anastomosis around the scapula. First of all, why there is a need for the anastomosis? Two arteries or 2 to 3 arteries joining, and thereby what happens is they form a network of arteries so that the blood supply is not compromised. The shoulder is a highly mobile structure, so with great degree and also range of mobility. So when you move in most of the directions during various activities of the limb, there is quite a fair chance of the blood vessels getting kinked or compressed. In that case, what happens is the blood supply should not be compromised to the limb. So for that reason, what happens, the anastomosis actually exists here, and it is actually called as the anastomosis around the scapula. Now this anastomosis takes place between the subclavian artery and the axillary artery. More importantly, it is between the first part of the subclavian artery and the third part of the axillary artery. So it is between the first part of the subclavian artery and third part of the axillary artery. Here you are able to see here the trunk. If it is a single trunk, if it is this is getting compressed anywhere, So this wide area can be bypassed, that is starting from the second and third part of subclavian, first and second part of axillary. So there exists a communication between the first part of subclavian and third part of axillary artery. Now, where all actually this anastomosis is present around the scapula, there is a arterial anastomosis around the body of the scapula, and also there is anastomosis around the acromion process of the scapula. So anastomosis around the body and anastomosis around the acromion. Now coming to the anastomosis around the body of the scapula, it occurs in three fossae, that is subscapular fossae, and behind you have supraspinous and infraspinous fossae. So what are the arteries taking part? Mainly suprascapular artery. Okay. So here you are able to see the suprascapular artery, which is a branch from the thyrocervical trunk. Okay. So thyrocervical trunk. Suprascapular artery, which is a branch from the first part of subclavian artery, that is the thyrocervical trunk, will give suprascapular, transverse cervical, and one more branch is the inferior thyroid artery. Three branches from the first thyrocervical trunk: suprascapular, transverse cervical, and inferior thyroid. Transverse cervical is again going to into superficial and deep cervical. Okay. So branch from the suprascapular artery, then branch from the deep branch of the transverse cervical artery, and a branch from the circumflex scapula, which is from the subscapula. Circumflex means it winds around the scapula, that is why it is called a circumflex scapula, and it is also a content of the upper triangular space. So mainly it is anastomosis between the suprascapular artery, deep branch of transverse cervical artery, and circumflex scapular artery. The branches of these three arteries ramify over the three fossae of the scapulae, that is the subscapular fossa in the front and supraspinous and infraspinous fossa behind. Okay. Next, coming to the anastomosis around the scapula, around the acromion process. So around the acromion process, acromial branch of thoracoacromial artery, which is from the second part of axillary artery. So here the anastomosis around the acromion process is between the second part of axillary artery and the first part of subclavian artery. So acromial branch of thoracoacromial artery, acromial branch of suprascapular artery. Suprascapular artery also is giving an acromial branch, and one more from the posterior circumflex humeral artery. Okay. So these three arteries, from the branch from the posterior circumflex humeral, branch from the suprascapular acromial branch, and branch from the thoracoacromial. Thoracoacromial artery gives four branches, no? Acromial, clavicular, pectoral, and deltoid, of which acromial branch actually takes part in the anastomosis around the acromion process. Okay, so as I told you, it is between the first part of the subclavian and the second part of the axillary artery. So finally, we have come to the clinical aspects of today's session. So the first thing will be about the deltoid muscle. So deltoid muscle is mainly used for intramuscular injections because it is a very well developed muscle, multipinnate muscle fibers. So naturally you have thick muscle fibers present in it. So only thing is, what happens, you should have 2 finger breadth from the head of the humerus. So thereby this area below the 2 finger breadth from the head of the humerus is a safe zone for you to give intramuscular injections along the middle of the muscle, because above that you go, naturally sometimes accidentally you might go and injure the axillary nerve which is present along the surgical neck of humerus. So this is the common site of intramuscular injections, the deltoid muscle, because other than that no other important structures are actually present in that region. So deltoid muscle mainly intramuscular injections. So lesions of the axillary nerve, mainly when the lesion of axillary nerve takes place. So here you are able to see fracture of the surgical neck of humerus. So the surgical neck of, when it is fractured, there will be involvement of the axillary nerve. That is one thing during the fracture of surgical neck. Or inferior dislocation of the shoulder joint, as I have mentioned earlier, can also cause this. And sometimes when you use crutches improperly, if you don't use the crutches properly, it will put pressure over the axilla, which in turn might compress the axillary nerve. So here what you are able to see here is the head of the humerus dislocated from the glenoid fossa of the scapula, inferior dislocation. So when it comes down, naturally it is going to stretch the axillary nerve which is present here. So surgical neck fractures and inferior dislocation of the shoulder joint is very much prone for the axillary nerve injury, and also improper use of clutches. So when the axillary nerve is damaged, what does it lead to? What are the signs and symptoms? So here mainly paralysis of deltoid and teres minor. So the muscle supplied by that nerve will get paralyzed. So naturally what happens is you won't be able to abduct the arm beyond 15 degrees. So impaired abduction between the 15 to 90, or little bit, if you actually push it, then definitely from 30 to 90 it is impaired abduction. So wasting of muscle. Here you are able to see how the muscle is actually in a very healthy condition, but here muscle wasting as takes place because it is denervated and it is not being used. Wasting occurs very rapidly and atrophies. So this rounded contour of the shoulder is lost, and you can see the projection of the greater tubercle of the humerus. Okay. So paralysis of deltoid muscle results in impaired abduction, wasting of the muscle, which leads to the muscle atrophy. So the deltoid muscle atrophies due to the damage to the axillary nerve, and you will also don't have any sensation over the upper lateral part of the arm, because the cutaneous innervation is again by the posterior division of the axillary nerve. Okay. So mainly this area you will have loss of sensation which is supplied by the axillary nerve. So with this, today we have discussed in detail about the deltoid muscle. Then we have discussed about certain intermuscular spaces. Then about the anastomosis around the scapula, axillary nerve and its applied anatomy. So thank you very much for your patient listening. We will meet again in one more topic.